Our next lecture is going to be on labor, delivery, and physiological changes after birth. Okay, the first term in this section that is important for you to understand is parturition. And parturition is the process of giving birth. There are 5 distinct events that make up the birthing process. The first is rupture of the membranes. Then you have the dilation of the cervix, contraction of the uterus, separation of the placenta, and then shrinking of the uterus. And we'll talk about each one of these stages, each one of these events, rather. Okay, there are 3 stages to normal labor, but there are some terms that we need to discuss before we get into the stages. And the first term is primigravida. Primigravida is the term used to describe a mother that is in her first pregnancy. And then multigravida means that the mother has been pregnant at some point in time before. With multigravida, it doesn't mean that mom has several children. It just means that she has been pregnant before. Whether that pregnancy ended with a viable delivery and a healthy child is another story. But just the fact that a woman has been pregnant previously puts her now at multigravida. Braxton Hicks is just the term used to describe false labor. With Braxton Hicks, the person or the mother will experience some contractions, but they are rhythmic and fairly mild compared to a true contraction. Now, stage 1 of labor is the first stage, obviously, and this is where you will have effacement, meaning stretching or thinning of the cervix, and also dilation, which is widening of the cervical opening. Effacement of the cervix is measured as a percentage, so you'll hear them referring to mom as being 100% effaced. If they are at 100% effacement, the cervix is imperceptible against the uterine wall. Dilation, however, is measured in centimeters. So they will look at the cervical opening and measure how far apart the walls are. And whatever that centimeter reading is considered the dilation. The cervix is fully dilated once the centimeter reading is at least 10. Effacement and dilation are a result of the continuous pushing of the amniotic fluid and the fetus against the cervix, resulting from uterine contractions. In normal labor, the cervix primarily effaces during the early portion of stage 1. And dilation is minimal at first and then progresses rapidly towards the end of stage 1, when effacement has almost completed. Now, effacement and dilation of the cervix is illustrated very well on page 55 in your textbook. Shows what it looks like before labor, shows what happens when the cervix starts to stretch and thin in early effacement, and then shows the difference between how early effacement, complete effacement, and complete dilation look. So you got the 2 depictions. One is a primigravida depiction of how effacement and dilation would result. And then you have multigravida depiction of how dilation and effacement will progress. There is a difference because the body has been through it once before. During the initial contractions in stage 1, the uterus differentiates into a thick muscular upper portion and a thin lower section. This allows the contractions to push the fetus down the birth canal. Now, stage 1 ends when the cervix is completely dilated and effaced. It averages between 7 to 12 hours in multigravida, but can be up to 18 hours in primigravida. Okay, that leads us into stage 2. With stage 2 of labor, the position and engagement of the fetus is what we focus on. And then, of course, the delivery of the fetus. So the position and engagement of the fetus is very important because it will determine whether you can actually move forward with a vaginal delivery. Your text shows here that 95% of all births occur with the fetus in the head down, or what we call the vertex position. This is not always the case, though. There is another 5%, right? But for vertex positions, your textbook shows you nice pictures of how the baby can be located. And you may hear these acronyms thrown around during labor and delivery situation. So depending on how the baby is turned will determine the position, the vertex position. So if the baby is, if you're looking into the pelvic region and the baby is facing to its right, we call that an ROP. If they're facing to the left, it's called the LOP. And if they are anterior, that means that their face will be facing actually the back of mom, and that's called the ROA. If they turn to the right, and if they turn to the left, that's LOA. And then you have the transverse, where they're turned to their side. They're not turned forward or backwards, they're turned to their side. And that's called ROT if they're turned to the right, and LOT if they're turned to the left. So as the head advances down the birth canal, it reaches different degrees of engagement or stations. And the stations are the ones that I just described. The station is the location of the head as it relates to the level of the ischial spines on the maternal pelvis. Stations are expressed in centimeters above the ischial spines as negative numbers and below the spines as positive numbers. So the head is said to be engaged in the birth canal when it reaches the spine or a station of 0. So when we're talking about those stations, if you look in your text on figure 3-3, it shows the 0 reference all the way down to a positive 5 and then up to a negative 5. So this baby here in this picture is shown to be at a positive 2. As the fetus, I said it right, positive 2. Okay, as the fetus begins its descent down the birth canal, the head turns to a face-down position to accommodate passage through the pelvis, which can be seen in figure 3-4. All the different engagements and extension, rotations, internal and external, and then the baby is actually rotated, a shoulder rotation, and then expulsion through the vaginal opening. But upon delivery of the head, the fetus rotates internally to ease the passage of the shoulders through the pelvis. The upper shoulder delivers first, followed by the lower shoulder. And delivery of the shoulders are very important because brachial plexus is a condition that can occur if the shoulders get hung up on mom's pelvis. The upper shoulder, I said that already, I'm sorry. Following delivery of the shoulders, the rest of the body exits quite rapidly. The umbilical cord will then be clamped following delivery, and the neonate begins to function outside the uterus for the first time. Now, the clamping of the umbilical cord is going to vary per facility, and actually may vary with each pregnancy, with each delivery rather, depending on what the birthing plan is of mom and dad. So if they've agreed to allow the clamping of the cord while baby is lying on mom's chest, then you may see the clamping of the cord happen a little later than immediately once the baby comes out. So that's something that they've been keeping that cord intact a little longer, letting mom and baby interact before they clamp the cord and whisk baby off. So the transition to the extrauterine environment or post-delivery environment is a critical time for the neonate and will be examined in more detail as we go along in this lecture. Now, stage 2 can last from 20 minutes to 2 hours, and that still be considered normal. Now, stage 3 of labor, we've gotten the baby out. We are at stage 3 of labor, and that is where the placenta is actually delivered. So the expulsion of the placenta that occurs in stage 3 can take up to 45 minutes for the body to basically reject the placenta. So 5 minutes all the way up to 45 minutes. After the delivery of the neonate, the uterus continues to contract, tearing the placenta loose from the walls. This may be assisted by placing the neonate at the mother's breast. It's another reason why we do this. Stimulating the secretion of oxytocin, which increases uterine contractions, and also manual pressure to the abdominal wall may also help expel the placenta. Over a short time, the uterus continues to shrink and eventually returns to its original position and size. Okay, we've talked about normal labor. Now we're going to talk about abnormal labor. And the first thing that can make the labor process abnormal is the length of time that it takes to get through stages 1 and 2. We've all heard of people saying they've been in labor for days on end. Well, that would not be considered a normal labor process. As we talked about earlier, stage 1 for primigravida should not last any longer than 18 hours, and for multigravida should last no more than 12 hours. The actual expulsion of the fetus should not take more than 2 hours, should not take more than 2 hours for primigravida, and no more than about 20 minutes for multigravida. So anything more than that would be considered abnormal labor. Now the fetal presentation, we talked about vertex because vertex is the normal fetal presentation, but there's also cephalic and breech presentations that are considered abnormal, simply because if the baby is positioned in a way that they can't get through the canal properly. That puts the baby and mom in a high risk situation. And anytime you have a high risk situation, is considered abnormal labor. So figure 3-5 shows all of the abnormal fetal presentations. And there's 5 types of breech: complete breech, footling breech, frank breech, face, brow, and shoulder. And how the baby is positioned basically tells you what's going on with the name of the position. So you have complete breech. That's where the buttocks is what is showing through the birth canal. Footling breech is when obviously a foot is what is presenting through the birth canal. And frank breech is where the baby is showing their backside, not their buttocks. So lower back is what will be showing there. For face, obviously it is the face that is presenting instead of the head. E is the brow, so more of the forehead that's being presented. And then lastly is shoulders. If the shoulders are what you see through the birth canal, then that is a problem. Most typically what happens is they have to go in and do a C-section if they cannot manually manipulate the baby to the vertex position. Vaginal versus C-section, and also spontaneous versus forceps. Those are abnormal. Vaginal, of course, would be a normal labor, but you may have to opt for a C-section if situations become critical. Spontaneous, of course, is more normal. It's normal for the body to just at some point reject the fetus so that it can be born. And forceps, of course, is considered an abnormal part of labor. If they have to physically go in, utilize forceps to get the baby out, then that falls under abnormal. Okay, fetal heart rate, we've talked about that already, but the increasing or decreasing of the heart rate, so bradycardia versus tachycardia, can lead you to be in an abnormal labor situation, because the fetal heart rate will drive whether you need to do something emergently or not. There's 3 types of decelerations, which we've talked about already in a previous lecture. But if the baby is experiencing decelerations and they are not normal, then we need to consider going in and getting the baby. So type 2 and type 3 decelerations could lead you to have to do further investigation to determine if there's some type of placental or umbilical cord or acidosis situation going on. If mom receives an anesthetic, whether it be local or general, there may be some concerns. Local anesthetic is usually okay. It's going to be just in the area of concern, like an epidural. However, general anesthesia, meaning you have to put mom totally under, mom is not given anything for local anesthetic, you need to consider that the fetus also will be receiving this general anesthetic. With that in mind, it could depress the fetus's ability to make its heartbeat and also for it to breathe. So when the fetus is delivered, stimulation may not make this baby start to breathe and bring its heart rate up. This baby may need Narcan. Tocolysis is the term we use for if we need to stop labor. So if mom presents and is in active labor, but we want to hold off on delivering that baby, you want to think about administering mag sulfate, terbutaline or brethane, or indocin. Those are all medications that we can deliver to mom that will hopefully cause us to gain a little more time before baby is delivered. With stress testing, intrauterine stress, whether it be a non-stress test or a stress test, if we find out that the baby is not responding well to stress, that could cause us to be in an abnormal labor situation, and we may have to get baby out in those situations. It really just depends. Everything is on a case-by-case basis, so we have to keep that in mind when you're working in L&D. There's no cookie cutter way to deal with what is being presented. Each case will drive what is going to be done. Of course, there are protocols in place, but what's most important is that you consider not just mom, but baby as well, in making the decisions on whether to do things like stopping the labor, or whether you want to go ahead and induce the labor or go in and take the baby. So I need to mention about tocolysis. There are drugs that will inhibit prostaglandin synthetase, such as indocin or indomethacin, but adverse fetal effects seen with indocin use include constriction of the ductus arteriosus, pulmonary hypertension, reduced urine production, and sometimes even small bowel perforation. So although it is still on the market, we still use it, it is still listed. It is not the go-to drug when we are trying to stop the process of labor, because we know that it has those adverse fetal effects associated with it. So the go-to drug is mag sulfate. It is an anticonvulsant drug, but it is useful and successful in stopping uterine contractions. It works by decreasing the muscle contractility, inhibiting uterine contractions. Neonatal effects of maternal mag sulfate administration may include things like decreased muscle tone, drowsiness, decreased serum calcium levels. There was a study that indicated the use of mag sulfate may protect against cerebral palsy in very low birth weight infants as well. So good things in comparison to indocin. Mag sulfate is the go-to drug when you are trying to hold back on letting mom deliver. But there are always side effects. So it just depends on, what outweighs the other. We know giving a tocilodic drug is going to cause things like tachycardia, hyperglycemia, hypokalemia, anxiety, nausea, vomiting. However, if it's going to allow baby to stay inside of mom, which is the best incubator possible, a little longer, the better off baby will be. Okay, prom is another thing that can occur that can cause you to be in an abnormal labor situation. And prom is nothing but premature rupture of the amniotic sac or membranes. And prom is considered to be true if the amniotic sac bursts before the 37th week. So after 37 weeks, we're fine if the water breaks. Okay, mom can also be given steroids to help increase surfactant production for the fetus. But if you feel like this baby may be delivered prior to 24 hours, then you do not want to give mom steroids. Okay, so if we think that we'll be able to hold off this delivery for at least 24 hours, but we know baby is coming soon and baby is in that early stage window where we know that type 2 cells may not be producing surfactant, then we can give mom steroid administration and then deliver the baby the next day or the next few days if we can hold out. Okay, and last but not least are the placental problems. This is the big one. With placental problems, it is very important to know where the placenta is located on the uterine wall at all times. Because if it moves or if it becomes dislodged, you are in an abnormal labor situation and you may have to emergently go in and get the baby to save both baby and mom. So we'll talk more about placenta previa and abruptio placentae on the abnormal delivery slide, on the next slide. Okay, abnormal delivery is actually termed dystocia. It's prolonged difficult labor and delivery. And the way that it is defined is that if it takes more than 20 hours to get through the first and second stages, mom is experiencing dystocia. Now, of course, prematurity would be considered abnormal as well, because if the baby is delivered prior to 37 weeks gestation, then that is not considered normal. Normal would be 37 to 40 weeks gestation. Now, there are several things that can cause dystocia. The two common ones are problems associated with the umbilical cord, and then the other is problems associated with the placenta. You can also have problems associated with your uterus, but those are usually things like the head is too big to come out the vaginal opening or through the pelvic opening, rather. And we call that cephalopelvic disproportion. And also if the baby is not positioned properly in the uterus and has some type of abnormal presentation, which we've already spoken about, that can cause you to have an abnormal delivery as well. However, the two main ones that can cause the delivery to last 20 hours or longer. It's problems with the umbilical cord and problems with the placenta. Now, where the umbilical cord is concerned, it passes through the cervix into the birth canal. If it does so ahead of the baby, that is called prolapse. So if that cord somehow gets down and wrapped around and gets to where it is the first thing that you see trying to come through the vaginal opening, that is called prolapse. This problem is common in breech presentations, especially footling and transverse, and also in multiples. As the fetus passes through the birth canal, the cord is easily compressed between the fetus and the maternal pelvis. Compression of the cord can also occur in the uterus, and when it happens inside the uterus, this is called occult prolapse. Regardless of which type of prolapse you're talking about, prolapse is dangerous to the fetus because it interrupts the blood flow from the placenta to the fetus through the umbilical cord. If the umbilical cord is pinched or kinked somehow, then of course that would lead to hypoxia and eventually asphyxia to the fetus. And as you know, with asphyxiation, that is an emergent, get the baby out of there type of situation. So the way that you monitor whether prolapse is occurring is you monitor the heart rate. The intrauterine cord compression can be reduced by artificially increasing amniotic fluid. It's another way to help. And they do that by sticking a needle in the amniotic sac and infusing fluid into the amniotic sac. By increasing the amniotic fluid volume, there is more room in the uterus and less chance of cord compression. Now, placental abnormalities have to deal with two terms I mentioned on the previous slide, which is placenta previa and abrupto placentae. Those are big to-dos. When you hear those terms, think emergency. So in most pregnancies, the blastocyst attaches itself somewhere near the upper portion of the uterine cavity. When the implantation occurs in the lower portion of the uterus, it is called placenta previa. So you don't want it in the lower portion of the uterus because it gets in the way. There are three varieties of placenta previa, and they are shown in your textbook on figure 3-8. So you can have it where it is in the lower part of the uterus, but not obstructing the cervical opening. So you have low implantation, but not necessarily getting in the way. Then you can have partial placenta previa, where the placenta has implanted on the lower portion of the uterus, but it is also blocking a portion of the cervical opening. And then total placenta previa, the placenta is actually located to where the cervical opening has no entry or exit point. It is covering it up. Obviously, you won't be able to spontaneously deliver that baby vaginally. That must be done via C-section for that baby. Now, abrupto placentae is different than placenta previa because with placenta previa, you actually have implantation. With abrupto placentae, the placenta separates prematurely from the uterine wall. That's a big deal because separation of the placenta frequently causes labor to start. And if you are at an early week gestation, you don't want that to occur. So such a pregnancy is precarious at best and requires very close monitoring by the physician. Premature labor and delivery occur more commonly with abrupto placentae, obviously. This is due to the frequent commencement of labor when the placenta separates from the uterine wall. Maternal mortality rates range from 2 to 10% in severe cases, ending in fetal death. Fetal mortality approaches 50% owing to the acuteness of blood loss. So mom's losing blood, baby's losing blood, baby's no longer attached to mom, so it's having to circulate its own blood and nutrients and such internally. The most common cause of abruption is maternal hypertension of any origin, including preeclampsia. And preeclampsia is just the term used for when mom has hypertension due to constriction. So maternal preeclampsia is the development of hypertension with proteinuria, edema, or both. It is unknown. It is of unknown etiology and usually presents after week 20 of gestation. Also, abruptio placentae may be present in a mother with a history of abruption, a high number of previous pregnancies, some type of trauma, a short umbilical cord, sudden uterine decompression, uterine anomalies, and compression of the inferior vena cava. All of those kind of go hand in hand with abruptio placentae. Placental separation can be partial or complete. We already talked about that. But the key is the bleeding. If bleeding from the vagina is present, it is called an apparent hemorrhage. If no bleeding is evident, it is called a concealed hemorrhage. We did talk about the figures that showed abrupt placenta previa, but on figure 3-9, you have depictions of abruptio placentae as well. So figure 3-9 shows the different combinations of abruptio placentae that are possible. The mother and the fetus are at risk in the presence of placental abruption. So severe abruptio placentae is clinically manifested by vaginal bleeding, tetany of the uterus, tenderness of the uterus, absent fetal heart rate, and then maternal hypovolemic shock. The risk to the fetus is the loss of placental surface area, resulting in severe fetal hypoxia and asphyxia. Premature separation of the placenta may also lead to fetal blood loss with subsequent anemia and shock. Treatment of abrupto placentae includes strict management of blood volume, maintaining a hematocrit volume of 30%. This is done by IV administration of blood or crystalloid solutions. And then the mother is instructed to lie in lateral position to allow maximal placental circulation. And then intensive monitoring of both the fetus and the mom is essential. And those in charge of care should prepare for emergency delivery or C-section if the signs of maternal shock of fetus or of fetal distress are seen. Okay, the last two things to mention here about abnormal delivery is cesarean delivery and multiple gestations. With cesarean, you have a surgical incision that is made through the maternal abdomen, and It is performed under anesthesia and should only be done in the presence of the following indications: prior cesarean, dystocia, breech presentation, or fetal distress. Most cesarean deliveries result in a healthy neonate, but there are some possible complications, and the most serious complication arises from accidental cutting of the placenta, umbilical cord, or the fetus during delivery. This can lead to serious hemorrhaging and anemia. Other complications include TTHN, transit tachypnea of the newborn. This syndrome, which we'll talk more in depth about later, is thought to be caused by the retention of lung fluids, normally expelled as the fetus is squeezed through the birth canal. So if you do a cesarean, there is no delivery through the birth canal, even though they've done some things to make that better, but we'll talk about that later. And then multiple gestations is considered an abnormal delivery because you have several babies that are in there. So twins, triplets, etc. The incidence of mortality is higher the more babies you have in a single gestation. So this is due in part to the high incidence of premature labor and delivery in multiple gestations. There is also an increased incidence of congenital abnormalities, growth retardation, bacterial infection, and hypoglycemia. Now, several factors increase the incidence of multiple gestations. History, if you got a family history, familial inheritance, puts you at a predisposition to be the carrier, female, to have fraternal twins. So that might be the case in your family, but it may be the case in other families where every other female in the family has identical twins. So there's a high incidence of multiple gestations among African Americans, and very low incidence in the Asian population. Multiple gestations are also more common in the older female ages 35 to 39. Also, the administration of Clomid to induce ovulation is associated with a high incidence of multiple gestations, as is the administration of gonadotropins. So if a mom has been having problems conceiving and she goes to a reproductive specialist and receives gonadotropins, then she could end up with multiple gestations. It is also speculated that there is an increase in twinning following discontinuation of oral contraceptives. Twinning is the most common type of multiple gestation. It occurs in about 1 out of 99 pregnancies. 2/3 of all twins are fraternal and dizygotic, and arise from the fertilization of two separate ova. Fraternal twinning is an autosomal recessive trait that is carried by the daughters of mothers of twins. The remaining 1/3 are identical twins originating from one ova and one sperm. They are of the same sex and have an identical appearance. In contrast to fraternal twins, identical twinning is a random occurrence. Identical twins have a higher mortality rate than do fraternal twins. Whenever there is a shared placenta or umbilicus between twins, there is an increase in the risk factors. One twin may receive more nutrition or actually deplete the other twin. For some reason, the second twin is often more compromised than the first, and it appears that female twins are healthier Then they're wimpy male twins. Okay, once the baby is delivered, obviously they will have to adapt to our environment, which is what we call extrauterine life. So the first breath is a big to-do, obviously. The baby in the womb was not breathing our gases. It was receiving it from mom through the placenta. So once the baby comes out and is cut off from the placenta, the PaO2 obviously is going to fall and the CO2 is going to rise. These two changes will stimulate the chemoreceptors, which respond to oxygen and CO2. And because of the stimulation of those chemoreceptors, the respiratory center in the brain will then be stimulated, and the brain signals will send the respiratory center will send signals to the muscles of ventilation, like the diaphragm, to start the breathing process. So this birth asphyxia, because that's what asphyxia is a decrease in oxygen and an increase in CO2, is probably the most powerful influence on stimulating the initial breath. There's a second contribution to the first breath that occurs during vaginal delivery, and that is that the fetal thorax is compressed as it descends through the birth canal. That is why they try to create the same environment when the baby is delivered via C-section by only making the opening very small to create that suctioning. So as it exits, the chest expands to its original size and shape. And as a result of the expansion is the entry of air into the lungs. Additionally, during vaginal delivery, the lung fluid is expelled, creating an empty volume in the lungs to be filled with air upon delivery. Now, the third influence is the abrupt change in the environment from dark and warm uterus to bright, cold, and noisy delivery room. These changes, combined with the physical handling of the neonate, invoke the crying reflex, which also helps stimulate that first breath. But in order for the neonate to breathe successfully, surface forces in the lungs must be overcome. In a term neonate, this is aided immensely by the presence of pulmonary surfactant, because surfactant greatly reduces the surface tension of the alveoli and reduces the work required of the neonate to take a breath. The initial pressure needed to overcome surface forces of the lungs has been measured and found to be as high as -100 centimeters of water pressure. Succeeding breaths require much less, obviously, because you establish FRC. The FRC is simply air that remains in the lungs following normal exhalation, which you already know. And as the alveoli are deflated following the first breath, the presence of surfactant prevents them from collapsing, allowing them to remain partially filled with air at the end of expiration. With each ensuing breath, a little more air remains, causing the FRC to gradually expand in the first few hours of life. And the result is that each successive breath becomes less difficult and requires less energy to accomplish. Thus, the healthy neonate quickly adapts to extrauterine breathing when the lungs are mature. Now, outside of taking that first breath, there is another adaptation that occurs, which is circulation that occurs in the womb is different than circulation that occurs out of the womb. So pressure changes is the main reason why circulation in the cardiovascular system will change. So shortly after birth, the umbilical cord is clamped. This seemingly minor occurrence causes great changes to take place in the neonatal circulation. Before clamping, the umbilicus and placenta provided a very low resistance to blood flow. Upon clamping the umbilical cord, blood flow to the placenta obviously is going to stop. The blood that would have gone to the placenta is now forced to perfuse the lower extremities. Being forced through a higher resistance causes arterial blood pressure to rise. The pressure increases back up through the arterial system to the left ventricle and atrium. As this is taking place, the neonate has begun breathing. The initiation of breathing reduces the pulmonary artery resistance, which was very high in the fetus when it was in the womb. Remember, when the fetus is in the womb, you don't need much blood flow going to the lungs, so the pulmonary arteries were constricted and had very little blood flow. Well, now that they have been delivered into our environment, the blood vessels should dilate and the pressure should reduce. So first, the actual inflation of the lungs, which results in the establishment of FRC, causes the surrounding pressures on the pulmonary vasculature. Reduces the surrounding pressure on the pulmonary vasculature. Second, the increase in PaO2 causes the pulmonary smooth musculature to relax from its constricted state. So you have the presence of PO2, which will help to dilate, and then you also have the reduction in pressure, which will cause the pulmonary arteries to dilate. These two factors cause pulmonary pressures to drop because you are dilated now, and in turn leads to a decrease in the pulmonary artery, right ventricle, and atrial pressures. The other change that occurs to the circulation is the closure of the shunts that are present in the fetus that should close once the baby is born. So the fetal cardiovascular system has undergone a complete reversal of pressures. Okay, the left side of the heart has converted from low to high pressures, and the right side has changed from high to low pressures. So while in the womb, blood was flowing from right to left through the shunts. Now, because of the pressure changes, you have that higher pressure on the left. It's going to close the flap that was there for the foramen ovale. So that flap is going to close so that now blood, when it comes into the right side of the heart, instead of going through that hole, it's going to go down to the right ventricle and to the lungs. During the last few weeks of gestation, smooth muscles surrounding the ductus arteriosus will begin to develop. These muscles remain relaxed and open owing to the presence of specialized prostaglandins. The production of these prostaglandins is enhanced by low levels of PaO2 and inhibited by high PaO2. So while they're in the womb, those prostaglandins aren't really working, but as you get high levels of PaO2, I'm sorry, I had that backwards. It's inhibited by high levels of PaO2, which you're getting from mom. But once you're delivered, you have low levels of PaO2, and therefore the prostaglandins will cause those muscles to constrict in hopes to close that PDA. As PaO2 continues to increase following initiation of spontaneous breathing, the production of ductal prostaglandins is inhibited. The absence of prostaglandins allows smooth muscle surrounding the ductus to constrict and closes it. The closing of this shunt stops the flow of blood from the pulmonary artery to the aorta. Failure of the ductus arteriosus to close may lead to further problems such as right to left shunting, meaning that blood is going to flow from the right side of the heart and then shunt back to the left through the PDA. Left to right shunting means that blood is shunting from the left side of the heart back over to the right, or actually into the lungs, and the resultant is congestive heart failure. The problems confronted when the ductus fails to close, we will talk about that more when we get to chapter 12. With the clamping of the umbilical cord, blood no longer flows through the umbilical vein or arteries. These vessels quickly constrict and eventually become supporting ligaments in the abdominal cavity. The ductus venosus constricts and becomes a ligament due to the same circumstances. Thus, the cardiopulmonary adaptation to extrauterine life is now complete. In a healthy neonate, one hardly notices that the changes takes place. However, when a baby does not adapt well, it can have some grave and sometimes fatal results. The cardiac and pulmonary systems are only two of many adaptations that the neonate must make. It must also provide its own nutrition, fight off infection, and keep warm, which we will talk about in successive chapters. That ends our discussion on chapter 2, and labor, delivery, and physiological changes after birth.